Yeah, in true collaborative fashion, she's going to click my buttons while I talk. So I'm going to talk really quickly about the role of the SLP in the big picture, and then we'll talk about applying it to our case study. So I like to tell patients who aren't sure what a speech pathologist does that I deal with issues from the neck up. But as Ash's wording of swallowing and functional communication, that's probably a little bit more of a formal and an appropriate definition. So just how common are the issues that we're talking about here with swallow and communication? For now, let's just consider the big three: aphasia, dysphagia, and what we call higher level language cognitive changes. When we consider multiple studies from the past 10 years, we find that aphasia affects about a third of patients who are recovering from a stroke. We find that fully half of patients are dealing with some kind of cognitive change or change to their cognition. And then finally, depending on the research that you hold to, dysphagia affects anywhere between a third to slightly over a half of patients recovering from stroke. So given the time frame that we're working with in the acute setting, the role of a speech-language pathologist at this level of care is more assessment-heavy and less treatment-heavy. A large part of our role is to try to articulate what the patient's needs will be in their next level of care. However, because patients at the acute level are often in a very dynamic medical state, their expected swallow and speech needs may be very different when you compare day 1 of their hospitalization to, say, day 5. So this means that our follow-up visits when they're in the acute level of care are often a mix of reassessment and therapy. So it's the next level of care that I was talking about, the rehab center, the skilled nursing facility, the outpatient facility, or at home with a visiting clinician, that the intense levels of therapy is completed. The exception to this being cases when a patient is dealing with an extended hospitalization and has needs that would benefit from early and intense intervention. Now, of course, we're also trying to balance this with the needs of the patient, so trying to keep that in mind with the big picture. Judging when a patient is most medically appropriate for our services benefits from expert input of the entire care team. This, of course, requires regular communication, primarily with bedside nursing, also with the patient and their family, but by extension to the entire care team. And this can include a hospitalist, neurologist, pharmacist, care coordinator, social worker, psychiatrist, other specialists on an as-need basis, which includes respiratory therapy, physical therapy, occupational therapy, pain and palliative consultants, dietitian, nutrition, ENT, cardiology, nephrology, GI. The list can go on and on. That's a lot of people to keep in tabs with. So when we talk about our case study, with Mr. R, he was not able to be seen by SLP services until day 4 of his hospitalization, and this was due to his vomiting and to his status of being intubated. So his plan of care began with dynamic monitoring of several evolving medical concerns. This was done not only through chart review, but through regular conversations with nursing that happened during rounding reports. In addition to his aforementioned GI issues and ongoing respiratory concerns, the site and size of Mr. R's infarct presented concerns for lateral medullary syndrome, which is commonly known as Wallenberg syndrome. So without even seeing the patient yet, but by seeing his scans, it was reasonable to expect that Mr. R would present with clinical symptoms that included difficulty swallowing or dysphagia, slurred speech, disordered vocal quality, which would change his speech intelligibility, as well as ataxia and facial pain. In addition to this, we also had documented baseline dementia and possible cognitive changes due to his ongoing respiratory struggles. So this raised concern for the patient's ability to independently remember and utilize any strategies communicated to him that would effectively address any of his issues. It should be noted that the area of cognition is one where the scope of practice of the occupational therapist and the speech therapist commonly intersect. While this can sometimes be confusing to some people, in reality it provides exciting opportunities for coordinated collaborative care that can result in functional outcomes that improve the patient's safety and their quality of life. So, as we said, it wasn't until day 4 of Mr. R's hospitalization that we finally had an opportunity to assess his swallow and communication function. This was notable for a wet, gurgly voice at baseline, which automatically is an indication of poor secretion management to us at bedside. He also presented with that harsh, hoarse voicing that we were expecting because of the site and size of lesion. So we did an assessment of swallow function with some ice chips, puree, honey thickened liquids. And he showed a delayed initiation of swallow and a prompt post-swallow cough, which alerted us to the fact that he wasn't really protecting his airway when he swallowed. He had to be suctioned after the assessment, and he was deemed a high aspiration risk. He was given a recommendation of NPO, and consideration of alternate means of nutrition, hydration, and meds administration was recommended at this time. So that's when we placed the Dobhoff. So this was information that was critical to the rest of the care team in their decision-making, not only for the hospitalist, but for the unit's pharmacist and also dietary nutrition. So the plan was to see him the next day, but other medical issues intervened and resulted in several more days of waiting. This waiting period was characterized by a prolonged period of this waxing and waning alertness, also agitation and delirium. During this time, he pulled his NG tube, and because time was progressing, a peg had to be placed in order to make sure he stayed well hydrated and proper nutrition. So intervention at this time was rather limited. It was really limited to suction-based oral care, and then speech therapist administered swallow trials with ice chips, and a lot of family education. In days 12, 15, and 17, we were able to see him a couple of times, but again, there was a lot going on. The patient fell, he pulled his PEG tube, had to have an NG tube reinserted. And so again, during this time, it was moving forward a little bit modestly. The themes of the visits were reassessing swallow safety and completing tasks that were designed to facilitate his swallow function and safety, both in secretion managements and then also looking forward. Thankfully, this patient also had a very, very involved daughter-in-law who spent a lot of time completing education and making sure that the rest of the family was well educated to his needs. First and foremost, making sure that the rest of the family kept him NPO when they came to visit. So, Mr. R's case was not uncommon in that sometimes we have a patient that shows incremental and encouraging progress, but then they have that Groundhog's Day moment where they're knocked back a few steps. In this case, for him, it was his reintubation and bronchoscopy that related to the mucus plug. Thankfully, after that, we were back at it again, but we did note that there were some additional voice concerns that we commonly associate with an extubation, notably a hoarse and a breathy voice quality. He also had increased expectoration, of thick phlegm that required more frequent suctioning. Swallow-wise, his initiation was getting better, but he was still showing clinical signs of aspiration penetration, so he was a continued high risk. So it's finally in sessions 6, 7, and 8, we're over 20 days into his hospitalization now, that the patient is stabilized medically. And as a result, we're able to see him move forward therapeutically as well. He was observed with increased success in his secretion management, increased timeliness of swallow, and these clinical symptoms of cough or throat clear after swallows were becoming fewer and further between. His family had established a clear routine of exercise tasks for him, both in oral care and swallowing of ice chips. And he was becoming increasingly compliant and independent in executing these tasks himself. Shortly thereafter, we were able to transition him to a very conservative diet. And by the time he was transferred to rehab, he had been successfully transitioned to a conservative diet of honey-thick liquids and pureed solids. I'm going to turn things over now to Katie Madden, who will speak on the role of occupational therapy and how it applied to our case study.
Thank you, Phil. In the acute care setting, my primary goal is to assess patients for their ability to complete ADLs and live safely in their home. If this is not able to happen, I will make recommendations on further therapy needs and discharge setting. Part of my role, especially with the stroke population, is to determine positioning needs, adaptive equipment needs, and cognitive status for ADL, IADL, and safety. Specific involvement from occupational therapy to facilitate ADL reduces the odds of a poor outcome. Therefore, we are usually involved within the first 24 hours of admission. Although working as different clinicians, the effectiveness of treatment does rely on all members of the stroke team, having a general understanding of all interventions and providing supported environment of healing and rehabilitation. There are many ways that we are involved together. These are some of the important areas. First, we cannot succeed without each other. We all rely on communication and assistance to give the patient the best care. As a patient in the ICU, like our patient, RS, we need to communicate to nursing, nurse practitioners, and physicians regarding the activity status, vitals, respiratory tolerance, and drains and tubes such as a ventriculostomy that, for instance, requires being clamped before we can change their position. In regards to positioning, occupational therapy assesses the need, fit, and tolerance and appropriateness of devices, and then nursing kindly carries out the plan or schedule. Physical therapy has the knowledge to don and doff items for treatment sessions, to educate family and notify occupational therapy of issues. In regards to fall prevention, we all provide education, follow safety protocols, and inform each other of how the patient is doing each day or with each session. And in regards to mental status, we all communicate on any area to focus on if there is a need or a specific aspect of what each discipline can focus on. Speech and occupational therapy can work together on cognitive status for safety, ADL, and communication. For rehabilitation following a stroke, there's current evidence in literature that supports OT interventions for acute care. It has been found that early occupational therapy to engage patients in ADL, mobilization, positioning, cognition, and visual tasks increase consciousness and well-being. Reducing edema, including elevation, light retrograde massage, and elastic gloves for edema has been proved beneficial. We can splint as needed. For the general use of orthoses, it is inconclusive actually of full benefit following a stroke, but it can be beneficial for spasticity when used intermittently. That means we need to assess whether someone is at risk of contracture, increasing tone, or whether we should leave the splint off. General prevention of contractures, skin breakdowns, falls, and deconditioning is another area of focus that we need to regularly assess and treat in our sessions. Daily stretching of hemiplegic limbs are recommended, and patients, family, and staff should be taught to do this with proper techniques. Positioning of the hemiplegic shoulder in maximum external rotation for 30 minutes a day in bed or chair has been studied. Use of a resting ankle splint at night or at varying times during the day, set to 9 degrees, is beneficial to prevent ankle contracture. Use of medications to reduce spasticity is noted to be effective, and therapists can recommend this to the team to determine if this is a good idea or not. As you can see from the picture, a patient does require a helmet for out of bed following a craniectomy. Occupational therapists can and do fit and issue the helmets to patients. A visual screen including ocular motor, scanning, tracking, fixation, confrontation, convergence, divergence, and reading should also be included. There is strong evidence that occupational therapy treatment focused on visual scanning training is effective. OT treatment focused on occupation-based tasks, cognitive strategies, and leisure tasks are supported by moderate evidence, and compensatory strategies specifically for problem-solving and planning have also been effective. Repetitive task training for motor and balance impairments are supported by strong evidence. Up to 50% of people that have had a stroke have a stroke-related psychological or mental disorder. That means that we need to provide therapeutic discussions with the patient and/or work on coping strategies. And education is a daily part of what we should be doing with patients, families, and other staff. In regards to our case study, SR, his cognition at evaluation was that he followed commands, demonstrated poor insight, intermittent confusion, and he was found to have dementia. For vision, he was tracking and fixating in all fields. For sensation, it was impaired throughout his right upper extremity, and he had decreased proprioception on the right upper extremity. His right arm was also weaker than the left. And whether you do all of the evaluation or even part of it, it's necessary to determine what the functional needs are going to be to help promote the patient to the next level of care. For his ADL status, you can see it as listed. He did use a PEG tube for a long time, so his feeding was NA. And as you can see, he did require a significant amount of assistance. So therefore, we worked on orientation, recall, and problem solving for cognition. For ADL performance, we worked on upper body dressing, lower body dressing, socks, and he required a long time to complete tasks. Functional transfers included toilet, bed, and chair. Therapeutic exercise and activity included working on the right upper extremity with coordination, tasks, reaching, and working on unsupported sitting as well. Splinting, we did assess him, but luckily for him, he did not need any. For fall prevention, we provided supervision during sessions, a safety belt, and chair alarm, and we all worked together to keep this a priority. In regards to his mental status, despite having to return to ICU and having setbacks, he did pretty well. It was found he did have dementia, so we did incorporate that into his treatment. He was also motivated for therapy along with his family, and luckily for him, he had the support of his family regularly. As you can see here, this is going to be a quick video of him performing an upper extremity task with his right arm, which is ataxic, and he's trying to move containers in and out of a larger container. So our patient did progress in therapy during his stay here. He had improved use of his right upper extremity for functional tasks, along with improved endurance. He was able to sit unsupported. He required less assistance for transfers, less assistance for ADLs, and he did make progress despite his medical issues. He had no need for positioning devices, and then he was able to transfer to an acute rehab center. Becky Brockson will now discuss the role of physical therapy with our patient.
Okay. That's okay. Sure. I'm going to go to the very end. So I did have a little bit about this VERT study, and anybody who's a PT who wants to order it, I have a reference, who wants to read it, I have at the end. I'll give you the follow-up on this guy. So I called the patient's daughter a couple weeks ago, and I got the follow-up on him, and she said that he's been home. He's so happy to be home. He attended acute rehab for 3 weeks. After the rehab, he went home with his family, and he was able to walk with he has a wheelchair, a walker, a shower seat. The daughter told me that recently her husband helped Mr. R into the house, and his wheelchair, he ran back out to the car to grab something, and when he came back in, Mr. R had gotten out of the wheelchair onto the kitchen chair all by himself. When she sent me this picture, she told me that he's walking with just gentle support required. So this is a patient. He experienced multiple complications in his recovery. He had an eventual good outcome returning home with his family. And I really strongly believe that the team approach, the interdisciplinary treatment that he received, played a strong factor in optimizing his recovery. And then we do have some reference pages for you at the end on some of the things that we used for this.